So Dr. Revathi already sent a set of questions to which I try to answer. So when to suspect a MRSA infection, and is that the clinical presentation, will it be different or not, and what is the line of management? So the clinical presentation of MRSA may not be very different, but we have to suspect this kind of infection in any keratitis if it occurs in healthcare workers, and also we have to keep in mind this is the most common post-LASIK infections nowadays, post-refractive surgery infections, especially in Western countries. So whenever we come across such infection which is not responding to the common medication, then we have to suspect this. And this being resistant to beta-lactam group of antibiotics, and also we can get even MDR, MRSA, like more than 1, 2, 3 groups of antibiotics also can be resistant even in MRSA, among the MRSA. And the ratio of MRSA incident is gradually increasing. Even with our own data, it is gradually increasing now. And this is a slide from the data from Madurai Arvindai Hospital last 6 years. The MDR MRSA, if you notice, it's almost 0% sensitive to any of the fluoroquinolones. So most of us, if you see a small infiltration or something, you'll start with a fluoroquinolone. But if it is going to be a MRSA, especially MDR, it won't be responsive. But if it is responsive, still luckily to vancomycin. And the other nice drug what we have to keep in mind is chloramphenicol. Many of us will not consider chloramphenicol for corneal ulcers, but still luckily we have, the government allows us to use that, and it is really a good drug. And coming to the deep fungal keratitis, whether intrastromal voriconazole, will it work? What is your experience? Before going to our experience, I'll also see the literature. Logically, it should work because voriconazole in higher concentration is fungicidal. So when you infiltrate it locally, it should work better. But we have to keep in mind we are loosening the stromal lamella when we are injecting something. So that can aid in spread of the infection also. That also we have to keep in mind. So what the literature says, very less comparative studies are there. And one study by Suleiman, they say like they compared topical and intrastromal voriconazole, and they said this is more effective. And another case series from Pondicherry, Arvind, initially they said it is working better when compared to natamycin. But the same group, when they did it as a proper randomized trial with Proctor group, they found out that it is not giving any additional help or in healing or anything. But and also like they also found out that the increase in perforation, but the TKP rate is almost same in topical group alone, natamycin, or if you give intrastromal. And the comments, there are some comments again as in MUT. In our side, it is more of Fusarium infection. Maybe it works in the Aspergillus area. But even in this group of patients, if you see Aspergillus and Fusarium, almost similar, equal percentage they enrolled, and still it is not working that much. That we have to keep in mind. And co-infections with other fungal infections, with fungal keratitis, do you come across often? Not very often, but we do come across with acanthamoeba fungal infections nowadays more and more. And this is not with contact lens wearer, remember, because when we recent academy meet, many of the doctors from Europe, they mentioned they are seeing in contact lens wearers fungus as well as acanthamoeba, especially Fusarium with acanthamoeba commonly. But we don't see that way. It is non-contact lens wearers only. But acanthamoeba, you can see fungal infections. When you start doing in all cases, the NNA also you include, we happen to see more and more co-infections. And also you can expect Pseudomonas infection, especially when the patient is using reconstituted drug like amphoB or voriconazole. They can come back with the Pseudomonas infection. So if a fungal infection is suddenly worsening, keep in mind that there could be more than one bug and go and look for it. And preferred drug of choice for Pythium. Pythium is nowadays we commonly come across. And what is the drug? Because this is a parafungus which is not going to respond to your regular antifungal drugs. Regular antifungal drugs, most of them act on the fungal cell wall, which is having ergosterol, but this one doesn't have that. So first report, the ex vivo studies have shown that antibiotics like linezolid and the other drugs, azithromycin, they are effective. And then first report from LVP came that there is a medical, 1% they can cure with medical therapy. And later the retrospective analysis showed the cases which were treated with antibiotic healed better. TPK rate is less than with antifungal, but if you see the TPK rate, it is not that much different. It's almost. So my point is, still these cases, it's better to go for early surgical intervention. Once you identify Pythium, I won't wait for it to respond to some drug or anything. Okay, initially you can start, but at the same time, if I can get a very clear margin in these cases, I would like to go for a surgical intervention, because reinfection is very common if you wait too long, because you can't, because these tentacle-like extensions, you can't assess how long they are going. And the presentation of Nocardia, generally this is a typical wreath-like presentation, superficial ulcers. Even in SCUD study, it showed that their scars will be very less, and they respond very well, usually in our cases, to amikacin. And but if you use steroid, as in SCUD, if you use steroid, they fare very bad, because they will present very deep infections can come and they won't respond, they will behave like fungal ulcers. So that we have to keep in mind. So the steroid is a no in nocardia keratitis, that we have to remember. Role of CXL, again logically it should work, because the procedure itself is antimicrobial quite very well, and also like it increases the rigidity of the collagen, so it can give more resistance to the infection spread, but the literature has not supported it so far. The RCTs are very less, low powered. Why we call low powered? Because Price et al. Already, even our group, we tried to do a randomized study. So you need at least 200 or more patients for a randomized study to see the effect properly. So, but some of the studies which came from our institute showed that it is, one is a proper randomized study also. It showed that it doesn't give any additional benefit in healing of the ulcer. Thank you.
Thank you, Dr. Revathi, for covering all the questions which I sent across to you. And as Rishi is setting up his presentation, I'll just ask a few quick questions for you. What do you prefer as the first line of management in a corneal ulcer? Topical medications in corneal ulcer. How would you approach a corneal ulcer?
Generally, we do already scraping. Like always, we do scraping, and smear study at least we'll do. So being a referral center, already the patient will be on the cocktail of some certain medications. So clinically, you can judge, and again you scrape, and whatever comes. If it matches with your clinical suspicion, then again we'll revise the medication what they are using. If already it shows signs of healing, I would like to go along with those medications only. And if it is not, then if the result also comes different, then only I'll change the medications.
I think we have the privilege of being in bigger institutions and having enormous support systems. But if it's for a practitioner, what would you think? How would you go about deciding monotherapy versus a combination fortified therapy?
Again, it depends the severity. And also the picture shows like a gram-negative infection or something like that, better you go for combination therapy, fortified drops. Otherwise, you can start with fluoroquinolones, the recent ones, even the 5% ones, you can start and see. And it's better always document. And another advice is, if possible, if you the number of infections you get more, keratitis you get more, at least have a microscope and try to scrape and see. Need not have a full lab setup, at least that much you can do. It's like endophthalmitis, first you give one injection and send to the doctor, same, I mean higher referral center, same way you can try. And it's always, if it is bacterial, if you strongly suspect, either go for a cephalosporin group. Cefotoxime, if you give, it covers both gram-negative, gram-positive. That way you can start, or at least a fluoroquinolone you start and then send. And don't wait too long to refer a patient if it is a corneal ulcer. And fungal, of course, most of the time we can recognize even by this thing. And if you are in a setup where you don't have a lab support, I don't find anything wrong in combining natamycin or one antifungal with one antibiotic. I don't find it very criminally wrong or anything. But don't wait for referral.
Yeah. So one more quick question is, I think of late we all faced the problem of, I think cefazolin-tobacin combination fortified is what we all traditionally use still, and I think it works well in the Indian scenario where infectious keratitis is a huge concern. And I think we were out of cefazolin for quite some time here. So what would you recommend in such a scenario for the practitioners?
Somehow from the beginning, I started using cefatoxime then cefazolin long back. During that time, again, we had some problem with cefazolin non-availability or something, some about 19-20 years back. So that time, me and Dr. J.K. Reddy, we started using cefatoxime, and I'm still sticking on to that. I think cefatoxime is still available, one thing. And another thing, chloramphenicol polymyxin combination is again another very good drug for corneal ulcers, especially in the early stage. We have to use it, and better not allow the general practitioners to use it for conjunctivitis and other conditions. I think they should be preserved for corneal ulcers.
One small point, Revathi. It's good to know the organisms in your particular area and also the sensitivity patterns. For example, in Delhi NCR, like we are in a private cum tertiary eye hospital, so, and most of the private practitioners in Delhi now send to one particular microbiologist around this area. So what we found in the last 3 years was, like Dr. Revathi said, you know, the sensitivity patterns are very different. Like when we discussed with the Shankar Netralia group, they said gatifloxacin was very sensitive. Whereas in our area, we have found in Delhi NCR, last 3 years, Gatti resistance was very common. Even though the drug companies would keep coming and telling you that 0.5% Gatti as in the form of better than 0.3%, but we found a lot of Gatti resistance, a lot of sensitivity to Amica. Surprisingly, gram-positive and gram-negative were sensitive to Amica. Ciprofloxacin, which was condemned as being resistant in the early days, now cipro sensitivity is now coming more commonly. So, you know, it's important to know in your particular area what exactly, if you do not have I mean, you can't send to a microbiologist, you can't scrape, you do not have a microscope. So it's better to know what are the sensitivity patterns if you're starting. Like at this point in time, no financial interest. Moxie sensitivity is pretty high, almost 85% for gram-positive bacteria. Vanco is still very sensitive. And also you find for us, unlike Dr. Revathi, cefotaxime and ceftazidime are showing a lot of resistances. So it's very important that I think at least in our local, I think we have tried sending the data to international journals who do not think it's very important to publish it. So at least in the local, maybe in your local ophthalmic society journals and other things, if you publish this local sensitivity patterns and the organisms, so it's easy for a private practitioner. For example, if you see an ulcer, you will give moxifloxacin more than gatifloxacin, and you would probably give an amikacin combined with a moxifloxacin at this point in time. 3 years down the line, things may still be different.
Just like to add something, now we also have another new fluoroquinolone which is available in the Indian market, which is levofloxacin 1.5%. It is a very good spectrum, but again I would suggest that you keep it reserved for the bad infections because it's probably your last line of defense.
Absolutely right, and I think we can go on and on with corneal ulcers for more than an hour.
Not only that, it can leave opacity in the cornea.
Yes.